Hi, I'm Julie Gralow, and I've chosen to review an abstract on HER2-positive early-stage breast cancer. Let me share my screen. There we go. So I'll be reviewing the results of the abstract of the primary analysis of the KAITLIN study, which was a phase 3 study looking at Trastuzumab Emtansine, otherwise known as TDM1, an antibody-drug conjugate, along with Pertuzumab, versus Trastuzumab with Pertuzumab and Taxane, all after Anthracyclines as adjuvant therapy for high-risk breast cancer. Here's the background. We know that chemotherapy plus HER2-targeted therapy is the standard of care for HER2-positive early-stage breast cancer, and early trials showed a substantial benefit for the addition of Trastuzumab to chemotherapy in this population. We also know that even with optimal care, recurrence occurs, particularly in the higher risk populations, and also all of this treatment causes toxicity. Up to 15% of patients with HER2-positive early breast cancer receiving HER2 therapy with chemotherapy will relapse or die within 5 to 6 years, and treatment with taxanes is associated with an increased risk of neuropathy, among other toxicities. So the phase 3 KAITLIN trial was designed to improve efficacy and reduce toxicity by replacing the taxane in the chemotherapy regimen and using Trastuzumab Emtansine, or TDM1, along with Pertuzumab. Here's the study design. This was a trial for HER2-positive early-stage breast cancer. Patients who enrolled either had to have lymph node involvement, or if their lymph nodes were negative, they had to be hormone receptor negative and with a tumor that was greater than 2 centimeters. All patients received 3 to 4 cycles of anthracyclines. This was followed in the first arm with a taxane, concurrently with Trastuzumab and Pertuzumab, and then the HER2 antibodies were continued for a full year. In the second arm, after the anthracyclines, the taxane was eliminated and TDM1 along with Pertuzumab was given for a full year. There were co-primary endpoints, which included invasive disease-free survival in the node-positive population and invasive disease-free survival in the overall group, including those node-negative patients. And here are the results. The experimental arm with AC, TDM1, and Pertuzumab did not reduce the risk of an invasive disease-free survival event in either the node-positive population or the whole group. These curves do not show a difference. It's also true that there was not a worse outcome from using this non-standard arm. A subset analysis was done, and looking at this forest plot over on the right, you can see that for none of the subgroups was there a preferable regimen, looking at the node status, looking at hormone receptor status, looking at the type of anthracycline received, or where in the world the patients were treated. Both of the arms were about equal. With respect to the toxicities, it was quite clear that the AC arm followed by TDM1 and Pertuzumab had a higher dropout rate across the whole year of treatment, and only 2/3 of patients completed all of the cycles of TDM1, whereas in the AC arm that was followed by paclitaxel or docetaxel along with the 2 antibodies, Trastuzumab and Pertuzumab, 88.4% of patients completed the full year of treatment of the HER2 antibodies. And you can see that difference here. 65% completed all of the HER2 therapy in the TDM1 group, and 88.4% in the non-TDM1 group. With respect to toxicities, well, serious adverse events or grade 3-4 adverse events were similar between the 2 arms as shown here. But adverse events leading to withdrawal from the TDM1 were, or the HER2 regimen, were clearly higher in the arm that received TDM1 versus the arm that had Trastuzumab instead. And if we look at the types of toxicities that were reported, we can see that even though this trial was designed to try to reduce neuropathy by eliminating the taxane, that indeed did not occur. There is some neuropathy from TDM1, and grade 3 or greater neuropathy across the year of treatment was 2.4% in the AC-THP arm and 3.9% in the AC-TDM1 Pertuzumab arm. So in conclusion, the KAITLIN trial did not meet its primary endpoints. The experimental arm of AC with TDM1 and Pertuzumab didn't demonstrate a statistically significant or clinically meaningful improvement in invasive disease-free survival. However, it's notable that 3-year invasive disease-free survival rates were high, 93 and 94%, in this higher risk population, and patients in both arms had good outcomes with respect to recurrence. The safety profiles of these two regimens were just different, and there was a higher proportion of patients in the experimental arm with TDM1 who withdrew from the post-chemotherapy HER2 treatment because of adverse events. The conclusion of the presenter at ASCO was that adjuvant Trastuzumab and Pertuzumab and chemo remains the standard of care for patients with high-risk HER2-positive early breast cancer. So let's put that in perspective to the African region. First of all, accurate HER2 testing is not always available to all patients and at all sites. Now, Trastuzumab was added to the WHO model list of essential medicines in 2015 after very careful consideration, but they put a caveat with that recommendation that this recommendation assumes that HER2 testing is available and that the drug is affordable in a given country. The WHO supports Trastuzumab in both early stage and metastatic breast cancer. And with respect to the cost, at least in the US, we now have 5 Trastuzumab biosimilars that are approved, which should be driving down the cost, although any of these antibodies are expensive to make. Now, Pertuzumab and TDM1 were evaluated for addition to the WHO Essential Medicines list in 2019 and rejected because the cost was not felt to be worth the degree of benefit that they offered. And I would go back to you all and say, what would be the criteria for the addition of these agents to standard practice in sub-Saharan Africa? It's not clear. Let's look at the degree of benefit in the adjuvant setting for various HER2 regimens. This is the data from the original trials done in North America of chemo with or without Trastuzumab. And this is an updated analysis looking at disease-free survival and overall survival with a median follow-up in this analysis over 8 years. And you can clearly see a difference between the two arms. There are clearly less recurrences and less deaths that is visible, clinically meaningful from the addition of Trastuzumab. Now let's look at the Affinity Trial, which was the trial of chemo Trastuzumab plus or minus Pertuzumab. This trial, done in the adjuvant setting and recently presented, although the disease-free survival is reported to be statistically significantly different, you can see that there's very little difference between the curves. The added benefit of the Pertuzumab is not great. You need a magnifying glass to see the difference. And overall survival, at least to date, and it's early still, is not different. And what about the addition of TDM1? Well, we do have approval in the US for TDM1 in early stage breast cancer if the patient has received chemotherapy and HER2 therapy preoperatively, and then at the time of surgery has residual disease. The KAITLIN trial looked at continuing the HER2 antibodies out for a full year versus switching to TDM1 after the surgery once it was known that all of the cancer hadn't been eliminated. So far, we just have disease-free survival reported in this trial, but again, you can see that the difference between the two curves at least is visible and appears to be clinically meaningful, which is why this has now become standard practice in countries that can afford TDM1. So going back to the applicability to Africa, I think that what's most important is access to reliable, reproducible HER2 testing. And once you have that accomplished, pair that with Trastuzumab therapy. And those should be the highest priority right now in HER2-positive breast cancer, whether early stage or metastatic. And then once that is established and affordable and occurring for all patients, we can move on to other HER2 targeted therapies. Thank you very much for your attention, and we are going to be taking questions in a little bit. Thanks.